Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now, let's get started. Today, we're going to dive into the scientific publication with the title Multiple Myeloma Extramedullary Manifestations. Kevin Danishvar, Wolfram A. Bosbach, Nando Merteniet, Gerd Nolge, and Frank Mosler. Introduction. Multiple myeloma is a malignant plasma cell dyscrasia and the second most common hematologic malignancy after non-Hodgkin's lymphoma. While plasma cell proliferation generally occurs within the bone marrow, extramedullary involvement can also be observed. The reported incidence of EMD of 7% is increasing, likely due to more sensitive imaging technologies and the prolongation of survival in multiple myeloma through the use of highly effective new medications as well as ISCT. Autopsy reports show a higher than expected incidence, with 63.5% of cases described as extra bone involved in one series. Extraosseous diseases occur more frequently in younger, male patients and non-secretory light chain subtypes, advanced stage multiple myeloma, extensive bone involvement, and plasma cell leukemia. The second most common affected sites include the aerodigestive tract, soft tissues, liver, spleen, lymph nodes, testes, kidneys, pleura, and peritoneum. Diagnostic imaging of extramedullary myeloma. Traditionally, the diagnosis and treatment of multiple myeloma have been triggered by clear end organ damage. However, owing to recently introduced treatment options that can extend patient survival and the increasing recognition of biomarkers that can be used to identify patients at high risk of progression to active disease, the diagnostic criteria have been revised. Bone diseases are among the most prominent features of multiple myeloma, and imaging plays an important role in diagnosis and follow-up, with each whole body imaging modality having different indications in different disease situations. Skeletal radiography has been the standard imaging procedure in recent decades, but should no longer be used unless it is the only option. Whole body low dose CT is a reasonable and cost-effective initial imaging approach. Whole body MRI is the most sensitive technique for detecting bone involvement and assessing painful complications. PET or CT is the best tool for evaluating treatment response. The importance of radiologists has increased in this scenario. Therefore, it is essential for radiologists to be familiar with the updated diagnostic criteria for multiple myeloma, the indications and limitations of each imaging option, and recommendations for follow-up in order to adequately support hematologists and improve the care of patients with multiple myeloma. Testicular involvement in the course of multiple myeloma is rare. The hematological malignant cells may remain in the testes even after chemotherapy because of the testicular blood barrier. Therefore, when reporting a whole body CT or MRI, attention should be paid to nodular tumor components or hydrocele. The imaging method of choice for evaluating testicular involvement is ultrasonography. The greatest advantage of PET or CT lies in its contribution to post-therapeutic evaluation, enabling differentiation between metabolically active and inactive lesions. Performing a baseline scan can also be helpful to facilitate comparison of pre- and post-therapeutic imaging findings. PET or CT also provides prognostic information about patients with multiple myeloma. Generally, more than 3 focal lesions, extramedullary manifestations, and a maximum standardized uptake value greater than 4.2 are associated with a poor prognosis. Discussion. Primary extramedullary myeloma typically presents at the time of initial diagnosis, whereas secondary extramedullary myeloma occurs during disease relapse. Plasma cell leukemia represents the most aggressive form of extramedullary myeloma. In some cases, patients may exhibit involvement of multiple extramedullary sites without concurrent bone marrow involvement. Diagnosis of extramedullary myeloma is established through the detection of soft tissue masses on imaging studies and/or biopsy confirmation. Assessing the therapeutic response of multiple myeloma using MRI involves identifying changes in the pattern of bone marrow involvement, such as transitioning from a seemingly normal or salt and pepper pattern to a diffuse or focal pattern, from a focal to diffuse pattern, or exhibiting an increase in the number and/or size of bone lesions, indicative of radiological disease progression. Conversely, complete disappearance of lesions and transitioning from a diffuse pattern to seemingly normal bone marrow signify complete remission. Radiological recurrence occurs when lesions reappear in the bone marrow that had become apparently normal following treatment. These classic MRI findings typically do not raise doubts during imaging assessment. However, when there is stability in the number and size of lesions and the pattern of bone marrow involvement, these findings should not be interpreted as indicating stable disease, as these lesions may be metabolically inactive. Other signs of treatment response, which would be classified as partial radiological responses in other neoplasms, including high signal intensity around or within the nodule on T1 weighted MRI, progressive disappearance of the lesion, absence or reduced enhancement on gadolinium enhanced MRI, and transitioning from a focal or diffuse pattern to a salt and pepper pattern may also constitute a complete radiological response, as these lesions could also be metabolically inactive. Early after treatment, chemotherapy and radiation therapy induce cellular necrosis with edema and an intense inflammatory response, leading to lysis of cell membranes and an increase in extracellular water content, facilitating water molecule movement, resulting in increased signal intensity on ADC mapping, 2-weighted MRI, and DW imaging. Subsequently, there is a phase of yellow bone marrow cell repopulation with an increase in signal intensity on T1 weighted MRI, a decrease in ADC, and a decrease in signal intensity on T2 weighted MRI. Several weeks after treatment, recovery of red bone marrow cells occurs, leading to a decrease in signal intensity on T1 weighted MRI. Recent studies involving a small number of patients utilized DW imaging to evaluate multiple myeloma treatment response, revealing that the increase in ADC, both qualitatively and quantitatively, is significant with a good response to treatment. Additionally, these findings demonstrate good reproducibility and agreement with laboratory response markers used in clinical practice. It was demonstrated that ADC values after induction therapy were significantly higher in deep responders than in non-deep responders, with percentage ADC increases of 46.96% and 78%, respectively, and specificities of 81.4% and 90.7%, respectively, in discriminating deep response to induction therapy. Regarding the evaluation of treatment response using dynamic contrast enhanced MRI, there is a significant decrease in the vascularity of the bone marrow after effective therapy. On CT scans and conventional film radiographs, modifications indicating treatment response often occur later or may not appear at all, even in patients who have achieved complete remission. Furthermore, due to the significant reduction in osteoblastic activity, many lesions fail to heal, potentially resulting in false positive results. Consequently, these methods are not ideal for evaluating treatment response in patients with multiple myeloma. Conclusion: extramedullary myeloma can manifest in various tissue sites. It predominantly affects the pleura, lymph nodes, chest wall, liver, skin or soft tissue, lungs, central nervous system, genitourinary system, breast, and pancreas. Testicular involvement in the context of multiple myeloma is an uncommon occurrence. Hematological malignant cells may persist within the testes post-chemotherapy due to the presence of the testicular blood barrier. When interpreting whole-body CT or MRI scans, particular attention should be given to nodular tumor components or the presence of a hydrocele. Ultrasonography is the preferred imaging modality for evaluating testicular involvement. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.